and we're hoping a few more people will join us. And I think we have some people up at North Shore who are watching and listening too. So thank you for joining us. I'm Deb Burnett. I'm the General Medicine Chief and the Lucent Director. And we want to remind you that this is our second monthly Lucent Symposium. Actually, we started in October. The November event coincided with MedEd Day. So this is our second Lucent event proper. And we intend to have monthly events this year to raise awareness, build a community of practice around primary care leadership. And then also we are in the recruiting phase for identifying resident and faculty scholars for the coming year. The events will continue to be open next year to all, including students, residents, faculty, whether or not you're an identified Lucent scholar. But look on our website and we'd be happy to give you more information about those opportunities. Meanwhile, we are here on the third Thursday of each month, bringing groups together around primary care leadership topics. So thank you for joining us. Our event next month will be on Thursday the 21st, and David Buchanan, who is the CEO of the Erie Health Center, will be speaking with us. We also, in January, will have Tim Ferriss on Tuesday the 19th as our Medicine Grand Rounds speaker. And he is the medical director of the Mass General Physicians Organization and a significant primary care leader there. So come at noon on the 19th and hear from Tim Ferriss. And then again at 4 p.m. on the 21st, we'll have David Buchanan. So I want to welcome today, Art Jones is our speaker. And he has, and I'm not trying to go through your slides yet. But he has an astounding history. Both started his training, at least part of his training was here. He was a medical student at University of Illinois, but then came here for his residency and cardiology fellowship at the University of Chicago. He then decided he wanted to open a community health center on the west side of Chicago, coming straight out of training. And he got supporters, including support from faculty and colleagues here at the university and throughout the city, and was able to open the Lawndale Christian Health Center, which he led for 27 years, learned to navigate FQHC and funding streams and all the things you need to know to run a successful community health center. And currently he's going to tell us more about working at the Medical Home Network, which is a Medicaid HMO, and he is also working at Health Management Associates, which is a think tank and consulting firm around practices for underserved patient populations. So thank you very much for joining us, Art.
Thanks, Deb. So I wish when I was training here that I had had something like Lucent. When I finished training here, I was really good at taking care of, I was telling Deb, acute leukemics, cardiogenic shock, and septic shock, but not so good at taking care of rashes and joint pains and other things that people are coming to. And the mentality at that time was if you just know how to take care of really sick patients, of course the rest would just come naturally. And I found out pretty quickly that wasn't the case. Thanks for having me come. Just to give you a little bit further the background. So when I was in med school at University of Illinois, I started to attend a small church on the west side of Chicago in North Lawndale. And I went to med school, the idea I was going to go overseas and do mission work. While I was there, the church one Sunday morning put up a blackboard and said, what are the needs of our community? Because we needed more than just preach on Sunday, we needed to meet the needs of our neighborhood. And so the first thing that went up on the blackboard was a safe place to do laundry, because the gangs had taken over the laundry mats. So the first ministry the church did was to get people to donate used washers and dryers, and we put them in the church so women had a place to come and do their laundry. But the second thing that went up on the blackboard was a place for affordable health care if you were uninsured. Because in 1979, if you were uninsured and poor, you could go to Cook County's emergency room where they may diagnose your heart failure, diabetes, whatever. But the waiting time, if you weren't part of their system to get into their adult ambulatory clinics, was 6 months. So there was a huge disparity in health. As a medical student, I thought it was all about access to medical care, and obviously that is an important part of it. There's obviously, I didn't know at that time, but there's many other determinants to health besides access to medical care. So everyone kind of looked at me, by now I'm a fourth-year medical student, and said, you can do something about that. I go, whoa, whoa, whoa. But the more we kind of thought about it, the more we felt like, that was what we were supposed to do. And so my wife and I moved into North Lawndale. We doubled the white population from 2 to 4. And I came here as a resident and stayed here and really got to support that I needed while I was here. I really learned to be a good doc while I was here, but also was living and learning from the community. And much of what I learned in my medical training didn't happen actually within the walls of the University of Chicago. They happened out in the neighborhood. We started our health center in 1984. We were funded by the Robert Johnson Foundation, um, and gradually got started and really focused on the just giving people good access to medical care, but also really the social determinants. I stayed there for 27 years, and even though I was the CEO, I found really good people to do the responsibilities of the CEO, and I went and saw patients 30 hours a week. So I was there for 27 years, and as during that time we did learn to take care of our Medicaid population under managed care. Have for over 2 decades assumed the near global risk responsibility for those patients. So we were financially at risk for not just only primary care, but for specialty care, pharmacy, diagnostics, behavioral health, emergency room, both facility and professional, and an upside and some downside risk on inpatients. So we really learned early on how we're going to manage the full continuum of care. And that's important lessons for us. We've done that for almost a quarter of a century, and learned that it was all about providing access to patients. It was all about looking beyond the medical problems of patients to look at their social determinants of health and helping them deal with those social determinants of health. And it also allowed us to redesign primary care. So, and I'll talk a little bit about that as we go through Medical Home Network. In 2008, so this slide, I think you guys all hear about the triple aim probably is more than you want to, but the triple aim is really about one thing, which is really about higher value. And the emphasis now is from the medical system is, can we provide high value care? Not just quality care, but care that really is cost effective and that meets the needs of so our patients are having a good experience. So a lot of the emphasis for primary care has been about patient-centered medical home, and certainly the Lawndale and the FQHCs that I work with now in the Medical Home Network are all certified or well on their way to becoming certified as patient-centered medical home. I think there was a expectation that was going to be a panacea, that in fact that if you just got through the certification process. And I think we're seeing some mixed results. There are articles that are coming out and some studies are coming out that are showing positive impact. And there's studies like this from JAMA a couple of years ago that really are large randomized studies that really showed that if you even once they got through the certification and they had significant financial incentives, that they were having a difficulty impacting some of the basic quality metrics and costs. So I think we have to realize that there's probably going to take more than just patient-centered medical home certification. In some of these cases, certification doesn't necessarily turn into practice, and so that's certainly one of the components. But I think there's much more to it than just doing that. And so as we look, we realize that just if the primary care is out there doing their thing, but there's the rest of the system, and we're not integrating with the rest of the system, that we're not going to get the outcomes that we're looking for. So there has to be clinical and we're increasingly realizing financial integration to be able to get the results that we're looking for. So although there's a movement towards ACOs in this country, and MHN is an ACO, not an HMO, that's okay. But we wouldn't take that title of being an HMO, but we'll take that we're an accountable care organization, accountable for the care and cost of the population. So we're seeing across the country that now up to a little over 23 million lives are within ACOs, and that's a 60% growth in the last 2 years, and over half of those are for government programs, both Medicare and Medicaid. And so the question is, if patient-centered medical home wasn't the silver bullet, maybe ACOs are the silver bullet. If you saw a couple months ago, the Feds released, CMS released the results for their Medicare ACOs, and you could see that that they're struggling. That for those that started in 2014, only 1 out of 5 actually generated enough savings to get any payment back. I think even that's not that surprising. I think the disheartening part is when you look at those that have been at it for 3 years, that only a third of them are actually generating enough savings to be able to get any kind of payment back at all. And what's not clear is, although CMS is benefiting from some of the savings that are being generated, even when they don't hit an MSR, it's not clear that those organizations, even if they get a savings payback, whether or not they have a return on investment, because they're putting quite a bit into this. So I think the jury still is out about as far as Medicare ACOs and ACOs in general, but that's the direction. Yeah, stop me if you have a question or I use. But basically, accountable care organizations are provider entities. When it comes to Medicare, about half of them include a hospital, about half of them don't. But they're physician organizations that come together with a common governance that take a responsibility for a defined population to provide the care and responsible for the cost of those populations as well. Um, so what about Medical Home Network, which is an ACO? We decided to focus on the Medicaid population. So there was a study that was done by the Comer Foundation. Gary Comer, who grew up on the south side of Chicago, was the owner of Land's End. So when he sold Land's End, he started a foundation and put a lot of the money into the Comer Children's Hospital. They also did a study looking at the health status of Medicaid children on the south and west side and their parents. And there was what you would expect. There was this huge disparity in health, and there was huge disparity in access. So as a result of that, the consultant, which actually turns out to be Health Management Associates, who I work for now, they did the study and they gathered and found out who was interested in sort of looking at a different approach. And so our health center, where I was the CEO, was one of those health centers that early on got together and sort of said, we looked at the study and said, maybe we could do something different. And I think what we concluded was that we were all trying the best to do a good job of quality as far as when people walk through our front door. We weren't doing such a good job when people weren't working through our front door, and when they're walking through somebody else's front door, we had no clue they were there, and information wasn't being exchanged, and we really weren't aligned. And we felt like our best opportunities to get better outcomes was, in fact, if we started to get together and started to share information and share it in a timely fashion, and we had aligned incentives to manage the population, and that really was the concept behind Medical Home Network. So we're covering the south and west, and now we also have FQHCs up on the north side. We have 9 federally qualified health centers and 3 hospital systems. Those 3 hospital systems are Rush, Sinai, and La Rabida. We were a pilot for the state, and I'll show you some of the results. We had 180,000 attributed lives when Illinois still had the PCCM fee-for-service program. We have about 80,000 lives now under county care who are contracted. And when we said, what was it going to take for us to be successful? We knew, first of all, we had to be really functioning as patient-centered medical home. So for us, it's not enough to be certified. We actually go in and see if you're practicing as a patient-centered medical home. And what we found was when we started to go in, most of our FQHCs, when they self-rated themselves and they've been certified and they self-rated themselves and we actually went in and saw where they're doing it, is there was a huge disparity. And our expectations of our FQHCs is that they act as patient-centered medical homes. And so they were given 6 months to actually become functioning in that fashion, and all of them have actually been able to do that. But even that was not enough for us. And we really had to look towards clinical integration, and we also had to have connectivity and data analytics to allow us to service the population. So what I was used to as a primary care provider was that I would often find out that one of my patients was in the hospital weeks later when they happened to show up with a piece of paper. And sometimes they were showing up a couple of weeks later after being an outside hospital with that prescription they were supposed to fill for the antibiotic that they never had filled. So just the whole lack of kind of knowing where our patients were and having that data was a problem. And once we had aligned incentives and we were around the table, as we said, could we actually change the way we were practicing? And I think what the challenge where we're seeing a lot of difficulty with ACOs is that they spend all their time on governance, which is the title of mine. But they spend their time on governance and they put a little care management in and they talk a little bit about IT, but they don't change the way they practice medicine. And if we practice medicine the same way we've always practiced medicine, why would we expect that we're going to get different outcomes? And I think that's why we're seeing ACOs struggle in general. It had to be, we realized that although we're starting off with one main payer, that it has to ultimately be able to impact all of our patients, that you can't have a model of care for just some patients and not the rest. And then ultimately we could do all we want, but if we didn't figure out how we're going to engage our patients and have them learn to take more responsibility for their health. And too often I think the model I grew up with, which was not working, was, just come to me, I'll tell you what to do, I'll tell you how to change your life, and just walk out the door and do what I said and you'll be fine. And we learned pretty quickly that that was not going to be the way to move. And finally, it was going to take leadership, and that's why I think I'm excited to see the leadership as the program that you guys are instituting, because it really does take clinician leadership to sort of say, we're going to move beyond the old model, and we're going to start to change. So this is the structures that we built. So we did spend time focusing first of all on organizational structure, because that is important, but it wasn't the primary importance. And we moved from having initially just a collaborative So we had several hospitals and several FQHCs that were sort of getting together on a monthly basis. One thing we did early on, which was important, is that we had a CEO only rule. So it was Larry Goodman, the CEO of Rush, was around the table. It was Alan Channing, who was the CEO at Sinai. It was the FQHC CEOs. And we learned early on that if we were going to really move forward, that it wasn't something that could be delegated. So if the CEO couldn't show up, they couldn't set a substitute. So that was really important to us. We also took an approach that I think is pretty unique in the country, which was an egalitarian approach. What's used to happen is that hospitals are used to dominating systems in relationships like this. They have forever. They tend to be the deep pockets. They tend to have the resources, and they tend to have the power. They're used to dominating relationships. From the very beginning, we said that that wasn't going to work for us. That we were going to come up with a structure that had 50% of the ownership and decision making done by the hospitals, 50% done by the FQHCs. And that was really key to us. That was a game changer because nobody could walk into the room and sort of say, well, you can say what you want, but I've already decided what I'm going to do because I'm the one who controls the ownership and I'm the one who controls decision making. We moved from that informal collaborative to a non-for-profit that allowed us to get some foundation dollars. So our early time was to attract foundation dollars to build our infrastructure. And then about a year and a half ago, as Bill and I moved towards mandatory managed care, we created an LLC and ACO. We still have the non-for-profit arm that has most of the infrastructure and IT that you'll see, but we now have an LLC, which is those 12 organizations, 9 FQHCs and 3 hospitals that are financially responsible for that population. So the governance model we took was not the traditional one where the hospital was in the middle, but we also were careful not to go too far the other way. So we knew the patient needed to be in the middle, but it didn't mean that the patient-centered medical home. So when I go around the country now in my consulting role, you go to New York where the hospitals are dominating all the Medicaid ACOs, and you have the FQHCs that are sort of in Rhode Island, for example. I'm on a project that says we want an FQHC-led ACO. Nobody's kind of, so it's either like one or the other. Either primary care docs or the FQHCs or say I have to dominate it, or the hospitals have to dominate it. But very few. I think the only exception I know is MHN, where we're sort of saying now what's really in our best interest is that we come together and we collaborate. So after we got our governance sort of straight up, we said, okay, now what are we going to do for connectivity and analytics? Because again, we realized that we had to share information. So we worked with a vendor out of Orange County that had learned how to map ADT feeds. So ADTs are admission, discharge, and transfer. So as soon as someone registers in the emergency room, you actually can map that. We worked with them to map it. So our FQHCs know the moment someone registers at UC's emergency room. So immediately we get an alert that says your patient is there. We know as soon as they're discharged, as soon as they're admitted to the UC's inpatient unit or discharged. We have 21 hospitals in Chicago that we're getting those ADT feeds. So and you're going to increasingly see that that's happening as HIEs start to develop. I know we're kind of slow here in Cook County, and the state HIE is probably going to go down. There's going to be a regional HIE. Some parts of the country are getting health insurance exchanges health information exchanges where they're getting these real-time alerts. You're going to see that increasingly. And but we've been having that now for over 4 years. But we knew what we learned early on was just the alerts were not enough, and that's what we're seeing. So a client of mine in New York said, yeah, they just turned on the regional HIE in the Hudson River Valley, and day one I got 77 alerts. What am I supposed to do with that? So it just becomes information overload. So what we realized early on was that we had to be able to take those real-time alerts and put them in context and turn them into actual tasks. So what we do is we built a warehouse that takes in the ADT feeds, but also has all the historical claims data. So for the 2-year pilot, we were getting weekly downloads from the state of all the claims data on our Medicaid patients, and we continue to now get it through the PBM and through the back office for the plan that we're contracted. We also have HRA data, so health risk assessment data. We realized that unlike what most people do, which is risk adjust based on diagnosis and claims history and utilization history, that we had to take into account the social risk factors. So we put together the data from our real-time pharmacy or next day pharmacy, real-time ADT feeds, historical claims data, and the health risk assessment data look at the social risk factors. And now we can create a profile and can risk stratify our patients and drive that information so that when our care managers get an alert that someone's in the emergency room, they know, is this a high-risk patient? Is this somebody who they haven't been able to contact at all? Is this a low-risk patient? And what are their diagnoses? And likewise, in the emergency room, so you'll see if you see one of our patients, you'll be able to go in and sort of say, okay, who does this belong to? Who is the primary care provider? Who's the care manager? You can actually tell if someone is at UC this afternoon for abdominal pain was in another, who had rushed emergency room that morning for the same thing. It's providing that type of information to be able to start to inform both the care manager and the provider at the point of decision making with information. And I think as we go forward, we're going to see more and more of that, where we stop making decisions in silos. So we spent quite a bit of time with that, and then we sort of said, okay, and this is really the various sources of information I just talked about. And our goal was to say, can we identify who the patients are that needed care management? And the recent craze is all about the super utilizers, those patients that are frequently in the hospital, in the emergency room, et cetera. And certainly you need to care manage that population. I don't know if any of you saw, though, the article that came out of Denver Health in August from Health Affairs, is that they looked at their super utilizers and they looked 12 months later. And guess what? 75% of the people who were super utilizers a year ago were no longer super utilizers. And a whole other group of people had come in and become super utilizers in the meantime, 75%. So what our goal was to sort of say, could we identify who the rising risk population was? And could we focus our care management not just on the super utilizers, but on that rising risk population? And the assumption we took was that it was really those social risk factors that made the difference. The patients that had chronic illness, the difference between somebody who has CHF who turns into a super utilizer tends not to be whether their ejection fraction got a little bit worse. Yeah, that does happen, okay? But what really the main determinant of our hypothesis was, the main determinant that made a difference between a CHF patient becoming a super utilizer was, what were those enabling services around them? So what was it? Difficulty getting transportation to the doctor's office? Was it difficulty affording the copay? Was it difficulty getting the food that you needed? What do you have? Unstable housing? It's those type of risk factors. And so we sat down as clinicians and sort of said, what are the 10 factors that we commonly saw in practice that we felt we could impact that made it difficult for patients to follow their treatment plans? So the doc's out there and he's forming all the treatment plans. And I can tell you early on, lots of frustration with me coming up with treatment plans that were never followed. But why was that? And were those things that we could actually change? Was it in fact, for example, that the patient was depressed? And that was the risk factor. So we came up with these 10 risk factors, and we did health risk assessments on our patients. We actually, over a 6-month period of time, did 60,000 health risk assessments. Those HRAs were done. They take 5 to 7 minutes. We first started to do them telephonically, whoever we could get a hold of the phone. Sometimes that meant literally 10 phone calls. Then people we couldn't get, we flagged in our EHR. So when they walked in, they hadn't had a health risk assessment done. They got them done at the practice. And we also then started to do them in the emergency room. So as we would get those real-time alerts, we could see right on the portal this person hadn't had a health risk assessment. So we actually got to 72% of our patients to get a health risk assessment. To put that into context, across the Chicago area, about 30%, health plans get about 30%. But guess what? The health plans are calling from a 1-800 number centrally, and we were calling from our practices. And patients tend to pick up the phone when they look on their caller ID, and it's their doctor's office on the phone. And when they pick up the phone, they say, I'm working with Dr. Jones. He wants me to ask you these questions for 5 minutes. Would you give me 5 minutes to answer? People tend to answer them. So we did 60,000 HRAs. Then we looked to see subsequently what was cost of utilization. Was it predictive? And we came up with a risk stratification protocol. And it turned out that, in fact, the social factors were very much predictive. That in fact, the more of those social risk factors you had, the higher your global cost of care, the higher your inpatient utilization, the higher your chance of being frequently utilized in the following 6 months. So that's really pretty exciting. There's really not, that data is not, we hope to publish that data. There's very little in the literature. In the literature, we know that if you're homeless, that increases your subsequent cost if you're unemployed. But I can't change unemployment. I can do something. We do ask about housing instability. That's the first data I've been able to see, that if you do those risk assessments, and you then can identify your subsequent global costs. Now the question is, now that we've identified those, can we actually reduce those risk factors and get reduction in global cost of care? And that's what we're in the process of doing. So I mentioned this, is that the idea is, that could we take that real-time alert, put it through our analytics, and then really inform our care managers so they can become effective. And then once we had that information, what else could we do as far as practice transformation? And so our focus clinically was improving transitions of care, because we know that that's often where people get re-hospitalized because there's poor transitions. It was care management of high-risk members, which we talked about. We're also focusing on physical and behavioral health integration. So for our Medicaid population, about a third of our patients are the newly insured under the Affordable Care Act. Guess what the number one diagnosis is for inpatient stay? Anyone have any idea? medical detox. Number one diagnosis. In fact, there are 4 times as many days for medical detox as the number 2 diagnosis for our ACA adult population. Those patients were cycling in like this. They were getting their detox, they went back out, they weren't given into outpatient care, and they went right back in. So we're focusing a lot on substance abuse this next year. We're also focusing on depression. All of our F3Cs are routinely, at least on an annual basis, doing a PHQ-2, which if it's positive, PHQ-9 to look for depression. But we're going beyond that to actually implement a collaborative care model where we'll use non-clinically trained behavioral people as the first lines of addressing it. There's not enough clinical licensed social workers and clinical psychologists and psychiatrists to take care of all the behavioral issues in the Medicaid population. So can we actually use non-clinically trained, and that's where the new workforce comes in, is can we train non-clinical people to actually start to be the first line of treatment for patients with depression. We also are looking at low-value medical practices. And there's a lot of low-value things, a lot of non-evidence-based things that we do. Sometimes I think people come out of training and it looks like they ordered lab tests the way they order vital signs. And it's just like everything gets ordered and there's not a whole lot of thought. Now, why did you order that TSH and that CBC? And they're almost this feeling of, because you kind of get used to it when you're doing the inpatient medicine. And the next thing you know, how often on inpatient do we ordering SMA6s and CBCs every day? You kind of think, why am I really doing this? What happens on the outpatient side as well? Why are we ordering CT scans of the back for low back pain when there's no neurologic symptoms? There's a lot of low evidence base that we focus on. And then can we really perform on the quality metrics? And can we become more member-centric? Can we provide people to access the care that doesn't require them to travel to our offices? So we had to come up with, as what we do, we were able to negotiate with our health plans. So we are delegated to do care management. And we pass those dollars down to our FQHCs. We don't do it centrally either. And our FQHCs hire their care managers and they're embedded within the care teams. As you look in the literature, what is it that was successful about when we looked at our care management model? What are the things that are at least a little bit? I don't know if any of you have looked at the literature on the success of care management. It's not really encouraging. There's not a lot of the biggest studies that are randomized are done with the Medicare high-risk population, and most of them didn't show a return on investment. In fact, the CMS funded 6 different studies with 34 different groups. Of that 34 different groups, one of them had a return on investment that was Mass General. But when they looked at what was the components of those that at least trended towards some success, it was things that are not that surprising. And in fact, telephonic care management is not very effective, and that's the methodology that most health plans do. But I don't remember the last time someone called you up, a stranger on the phone, and 1-800 number said, if you just do this, this, and this, you'll be healthy. And I said, hung up the phone and said, yeah, that's what I'm going to do. I mean, it just doesn't work, right? And so you have to build relationships face to face. There also to be a face-to-face relationship between the primary care doc and the care manager, as we looked in the literature. We had to make sure that the PCP had all the external data, so that patient's coming out of the hospital and the patient shows up and I don't have the discharge summary, I don't have the information. That was a problem. That we had to train our care managers in motivational interviewing and behavioral change techniques. We had to really focus on medicine reconciliation because a lot of rehospitalizations are related to the fact that I have a bag of medicine home. Now I come home with a new bag of medicine. Do I fill my prescription? Which one do I take? Do I take both? Do I take either? A lot of that goes on. And then really making sure that our patients had timely follow-up with their primary care providers. So we had to build a system to that. Because I just went to the FQCs and said, okay, I'm giving you these dollars to care management. But they didn't know, they would all said, yeah, I could do it, but they would all done it different ways and not with any structure. So we built a portal as part of our IT that really did this. So in our portal, we have our health risk assessment, and it automatically stratifies based on our algorithm to moderate, high, and low risk. And those that are moderate and high get a comprehensive risk assessment and care plan that takes usually an hour face-to-face to sometimes as long as 2 hours. And those patients that are moderate high risk get care plan updates. Those are high risk on a monthly basis. Those are moderate risk on a quarterly basis. But it starts to bring structure together. And what we felt like if we were really going to be successful, we found our patients were basically in 3 buckets. They either were either medically complex, behavioral health complex, or socially complex, or often we're actually a combination of 2 or all 3 of those. And could we actually, with our portal, say, you know what? Could we track and see, if we're really doing effective care management, we should be able to see that the complexity of our patients goes down. We should be able to see that those 10 barriers to care that we identify, if we're really doing effective care management, yes, down the road it should result in reduced ED visits and rehospitalizations and hospitalizations. But in the meantime, if we built the portal, and when I did my health risk assessment, the patient said, I have difficulty getting to my transportation to my doctor's office. When they come to do the care plan update, that portal automatically pushes that question back. Well, did you resolve it or not? And then we can actually track and start to see who's really doing effective care management. Because if I'm doing effective care management, I should start to see those risk factors diminish. And then ultimately, I think where primary care is going is we have to get away from fee-for-service medicine and the traditional requirement that the only way we get reimbursed is by doing face-to-face visits with billable providers. There are not enough primary care providers to take care of the Medicaid population, let alone the uninsured population. But we're still stuck on the system that the only way I get reimbursed is to have them see a physician or a nurse practitioner or a clinical psychologist or clinical licensed social worker. But we're also at the same time talking about team-based care. We're talking about both sides of our mouth. We're talking about team-based care, and that maybe the best person in the team to do the care is a nutritionist, or maybe it's a non-clinically trained person to take care of, to do care management. Well, if we're still stuck on, okay, it has to turn into a billable visit, or I hire a nurse. So what maybe the best thing for my patients is that instead of them, when their kids get sick, having to get on the bus and take a couple of buses and drag all 3 kids to come sit in my waiting area, maybe in fact if they could call and talk to a nurse, a triage nurse, that might be all they need, and isn't that much more member-centric. But how does the economics work for that in our current system? As I hire a triage nurse, that costs me with the benefits $100,000, all I've done is reduce my billable visits. So we have to move towards really a payment system that goes along with this. But I think the future for us is to start to say we're going to manage more of our patients virtually and provide people, and that's really what people are looking for. They're looking for access. There's a reason people are going to Walgreens for the walk-in clinics. It's not because of continuity. It's not because of the relationship. It's convenient. It's what they need to care. And we need to go beyond the convenience of a Walgreens walk-in clinic to provide good primary care and good access to our patients. We also have to look at models and realize that we're going to have to come up with new models too. And so one of the things we're developing is an ambulatory ICU approach. What traditionally has happened is that the really complex patients often get sprinkled across the primary care capacity, but there are patients that have very special needs. And can we identify who those patients are? And some of these patients are really complex from a medical standpoint. And so what we've realized is that it might be from a transition care, but someone comes into U of C and they're a train wreck, okay? And we send them over across the street to friend family to a PCP who might be a nurse practitioner, and there's nothing wrong with nurse practitioners or family practice docs, but they're not used to taking care of the train wreck who's coming out of U of C. So are we that surprised that when they go over that they're right back in over? So there are some patients that we need to have a transition clinic approach. That also goes for care management as well. There are some patients that we're over care managing. Our complex patients are so complex that they need specialty. So we use Rush to do that. So for example, we have about 15 patients that are on transplant lists. Many of the previously uninsured who now get Medicaid, those are the ones that are on our transplant list. They should have been on transplant list before, but they had no opportunity to do so. Well, do we really want the care managers at Lawndale, where I was, to be trying to do the management of a transplant patient versus sort of saying, that takes special expertise. I think we'll have someone do that. So we are starting to play with this idea of sort of coming up with an ambulatory ICU approach, but the idea that as soon as we can to start to move that patient back to the primary care setting. And then the other thing we're doing is we're looking at e-consultation. So the same vendor that we use that does real-time alerts, we've also developed e-consultation. So LA County, which is the second largest public health system in the country, has been using this vendor and has been doing e-consults for about 3 years. And what they found is that there's about 30% of patients don't really need to see the specialist face-to-face. Guess what? It's really hard to find a dermatologist to see a Medicaid patient. By the time they get in to see a Medicaid patient, often the rash is gone. Okay, so that's dermatology. But what we found is that you can take a picture and answer 3 questions and send it electronically to a dermatologist, and most of the time he can make a diagnosis. So and the nice thing about it is, what's the show rate for an e-consult? It's 100%. And the dermatologist then, when he's like has one of our patients who needs to see face to face, he doesn't show up. He has something else to do, which is to do 3 or 4 consults. So we're rolling out e-consultation with using the specialists at Cook County. and we're hoping that we'll get a similar response to what was happening in LA. And again, what's member centric? Is it better for the patient to go and be able to deal with this virtually, or can they really? Is it better for them if the issue can be dealt with electronically to do so? So I think we're going to see much more of that. So then beyond the model of care and the electronics is the patient is value-based payment. And so I think what we're seeing in the market right now is mostly fee-for-service medicine, a little bit of pay-for-performance, but the movement is towards increasing accountability. So with our medical home network, we are right now have a shared savings and global cost of care, but the expectation is that we will go towards capitated risk within 2 years. And it really is difficult for providers that are in that, because as you start to make that transition, you have to change the way you practice. And so if you're in this situation where, okay, which do I do first? Do I change my practice to work under a capitated global, where I have to pay attention to global cost of care, where I'm still being paid fee for service? And I think that's a dilemma that we're increasingly seeing. If you get too far ahead where you start to do practice transformation, you don't have a contract with an insurance company, you could go down pretty quickly. On the other hand, if you take accountability for cost and you don't haven't changed the way you practice, it's much faster to sign a contract that gives you risk than it is to actually deliver on that. And so we're really trying to move along the glide path for our F3HCs and our ACO to gradually they're taking more and more responsibility, but we're giving them the tools and helping with the practice transformation to handle that accountability. So as I mentioned to you earlier on, we were a 2-year pilot with the state of Illinois. So we had 180,000 members, Medicaid patients that had chosen one of our PCPs under the fee-for-service system with a PCCM fee. And we negotiated under that pilot for an enhanced care coordination fee and some pay-for-performance. We focused that pay-for-performance on getting patients back to be seen, because we only have a certain amount of money. So what we focused on is, could you get the patient back within 7 days of inpatient discharge? And could you make a call on all those patients within 7 days of an emergency room, and those that need clinically to be seen, see them face to face? So, and we used our real-time alerts to give that. So this is what the data was. So we had 180,000 lives, and the state's actuary then looked at 900,000 other Medicaid lives in the same geography, and they used the actuary risk-adjusted the patients. So this really is risk-adjusted data, and compared how our performance was compared to those other 900,000 lives. What we saw in the first 12 months is that the trend as far as cost of care, we were 3.3% better than the comparison group. By 24 months, there was a 5% difference. So it really showed already, even though we didn't have access to shared savings, just had to pay for performance and the care coordination, and had the IT system that we put up, that we already were down 5% in global cost of care, which was certainly really encouraging to us. This is our first year experience with, as you know, Illinois moved towards mandatory managed care back in July 2014. So this is 11 months of our first. Now this is not risk adjusted. We have half of County Care's membership, so we have 80,000 lives with them. This is the other 80,000 lives that are assigned to other F3HCs and to the county clinics. So it's not risk adjusted, so you have to take that within a grain of salt. But if you look at how we've done over most of the first year, is we have 17% lower inpatient utilization on a days per thousand basis. Our readmission rates are 15% better, and our ED visits are down 17%. And as I mentioned to you earlier, we were able to get health risk assessments done on 71% of our patients compared to 31% for the rest of the network. So it really does show that early on we really can start to make a difference and on global cost of care as well as some of the outcomes. Once we've generated savings, the whole idea is, what do you do with those savings? And so what our ACO does is we take some of those savings to reward our providers, and they reward it based upon several quality metrics, but also their ability to reduce the global cost of care for their subset of patients. We also then take the reserves and sort of say, we're going to do 2 things with the rest of the money. One is we're going to create reserves, because as we move towards a capitated system where we have downside risks, we have to have reserves to manage that. And the third thing we do is we take some of the remaining dollars and say, what are we going to invest in to get better outcomes next year? So this next year in 2016, our focus is on behavioral health integration. So we're training. We looked at our detox admissions and sort of said we have to have an alternative. So we're in the process of in 2016 training our several primary care docs in multiple sites in Suboxone treatment. We'll be working with our emergency rooms to actually start. There's an article in the New England Journal that shows the impact of starting Suboxone in the emergency room with close follow-up and give our patients an option as far as that goes. We're also implementing the collaborative care model that I mentioned earlier on with some of those resources. And finally is patient engagement. And I think this is really the biggest challenge. Part of our approach to patient engagement is to do face-to-face relationship between the care management and the high-risk member. But we're also we've also signed contracts with a text messaging contractor, and we're going to start to tie together a real-time alerts with text messaging. So actually, when our patients are sitting in the emergency room, you may see them getting a text message from us, because if we can start to tie those together, and not that we're trying to get people to leave the emergency room, but that's an opportune time when they're sitting, not having a great experience sitting in your emergency room for hours, and not just UOC's emergency room in general. Okay, it's not. We don't see a lot of people that are kind of walking out of the emergency room saying what a great experience it was. Okay. So that's an opportune time to get people engaged, and so we'll be using text messaging for that, for gaps in care, for other reminders and other health education stuff, and that's part of where we're moving as far as engagement. So I think I'll stop. At these are some of the lessons that we've learned over the years, but I'll stop and see if people have any questions. Yes. It is Care Message. There's two vendors that are really pretty far ahead. Care Message is out of California. They're in the San Francisco area, and they've done several studies. One of the things I like about them, a couple of things I like about them. One is they've studied the impact in several different models. Secondly, they have a real sensitivity to the safety net population, so they'll actually reduce their rates for providers that are in the safety net. So that's who we're looking to message. I could give you their contact information if you're interested. Yes. Thanks, Dan.
Did everybody hear that? Oh, okay.
Yeah.
So I'm wondering if you look at patient satisfaction as well as provider satisfaction, and have you tracked whether or not patients and or providers have moved in and out of this care system in any manner different or the same as other systems?
Yeah. So one of our concerns when we first started to do the real time is that were people going to react as this big brother? And what was really interesting is the care manager calls them the next day after they're discharged from the hospital or in the emergency room, and patients are uniformly. We've not had a single case where people have been concerned, like, how did you know? They actually, it's like you care enough to call me. So that's anecdotal. What we're going to be seeing soon is, which you probably know, is that one of the only medication requirements is that the health plans do a CAPS survey. So we're going to have data. Actually, and it's pretty expensive to do that, so we haven't done that. But we're going to be getting CAPS data comparing us to the rest of the network. And I expect what HFS is going to do is they're going to also benchmark that across the market. So we are going to have the patient satisfaction data that comes out of a CAPS survey to look at how we're doing compared to the rest. Our providers actually really like it because, as a primary care doc, there's nothing, you're really committed to serving your patients, and so you've got a full schedule, you're already behind, and that patient walks in and they've lost their housing, okay? And all of a sudden you got this dilemma because I'm already like 45 minutes behind, and now I have this huge issue, and what do I do? So for them to have care managers at the practice level, to be able to open the door and sort of say, here's Valerie, and she's my care manager, and she's going to help you know what resources we can have. It is a huge satisfier for them. So we haven't done it as far as, the other thing we were really careful about is that we have a clinical committee where we have, one of the things we did was as we built our ACOs, what most groups would have done was hire a full-time medical director. I'm very part-time as the chief medical officer. We had dollars to say we're going to hire a medical director. And we said, no, I think what we're going to do is take those dollars and pay for a half day a week of physician champion time in each one of our major practices. So the goal is that those physician champions are around the table on a monthly basis making decisions. When we came up with this health risk assessment, it wasn't all my ideas. I mean, I contributed, but it was a lot of people's ideas to sort of say, okay, and when we make policy decisions, like when we said we're going to move towards just being certified as patient-centered medical homes actually acting as one, that was the clinicians around them making that decision. They own it, and they start to see these results they get really pretty excited about it. I can tell you there's a lot of frustration out there with their experience with other managed care companies, where it's very much centralized care management. They're held accountable without giving them information, and they view us. And so the feedback we're getting without doing a formal survey is that we're by far the preferred. In fact, when the state allowed when they did enrollment, default enrollment for Medicaid managed care, that if a provider wanted to, they could communicate to their patient population, this is my preferred plan. All of our FQHCs put county care, with the exception of a couple that had ownership up in the east on the north side. All the rest of them said my preferred plan is county care because of the tools and model and just the sense of investment they had in MHM. Yes.
I'm wondering what you do for patients who don't speak English, who walk into an FQHC and are expected to fill out forms that are not translated into their language.
Well, that's not acceptable. So first of all, we translate, but I think what we really try to do is whenever we can is hire bilingual providers. The best experience is to be able to have someone, a provider you can speak. And that's not always possible. And then we hire a lot of bilingual nursing assistants. And so we really try, and then we do have translators for those. So if your provider doesn't speak Spanish and your MA doesn't speak Spanish, then we also have, on a particular day, then we do have translators in the room. And we translated all of our forms. And MHN, for the forms like the health risk assessments, all translated into Spanish. We don't have a lot of, within our population, there obviously are some people that speak languages beyond that, but it's such a small percentage within our Medicaid population that we haven't done that. But if we do, FPCs do all have for a line that they can call, a number they can call to get a translator on the phone, so someone comes in and they speak Polish, okay, that they can get someone on the phone. It's obviously not a great experience, but that's the best we can do. Good question. I think it's also cultural sensitivity. It's not just language, and so when we were at Lawndale and we got started, I hired from the community whenever I could hire from the community. And a lot of us lived in the community because we were not culturally sensitive. We needed to live in the community because that was the best education. But also as we hired, so almost all of our medical assistants and our lab techs and our a lot of our other staff, our translators, etc., are all receptionists. We're all people from the community, and it's a cultural sensitivity, not just a language issue. Yes.
Thank you so much for sharing a really exciting model. I think the main question I have is related to, so you've talked a lot about how you use care managers, and how do the care managers interact with patients inside the clinic as well as outside of the clinic? And then what other allied health professionals, again, interact with patients both in and outside of the clinic? And
Interact or track, I'm sorry.
Interact.
Oh, interact. So what we try and do is we really want, for people that are high risk and moderate risk, they're supposed to have updates on their care plan. So what we want to do is hook so that our care managers are alerted when those patients are there. So that I have a panel of patients as a care manager, okay, and I know when they're coming. And so we use the portal and the EHRs for that. Because again, as much as we can do face-to-face, we want to do so. Once you build a face-to-face relationship, guess what? Telephone starts to work because they start to do it. So I think we do use, and that's the advantage of having your care managers not in one centralized area. So, like Lawndale has 6 sites, so their care managers are spread across their sites because they want to take advantage of the fact that, hey, when that patient shows up, I can reestablish the face-to-face. As far as your second question is what other care professionals beyond care managers?
Yeah, what other allied health professionals do you use? So how do you use nurses versus medical assistants versus different types of nursing staff?
Yeah. So at Lawndale, we've had behavioral integration as one example for over 10 years. What we found is that when we would see patients with behavioral needs and we would refer them, the sure rate was really low. And so we've had a warm handoff. So we made the mistake of, okay, we're going to go hire. So we hired a clinical psychologist. And we treated them initially like we were the rest of the professionals, which is we'll give you an appointment to see them. That wasn't working either. The sure rate was even lower than the medical. So we've gone to a warm handoff system. So when, as a primary care doc, I saw somebody who needed to see the clinical psychologist, I did a warm handoff to them. And their schedule was built that that's really where they're spending their time. The follow-up for them is usually 2 or 3 visits, and if they go beyond that, they're referring out. Because otherwise, they can't do those warm handoffs. So that's behavioral health, and a lot of our clinics are using clinical licensed social workers and I think that within the practice, we use a lot of our care coordinators are a combination of non-clinical and clinical people. So usually they work in teams. What you really don't want to do is have an RN or a social worker doing things that could be done by a non-clinical trained person. So they work in teams. So those health risk assessments are not done by a nurse or a social worker; they're done by a community person. If if we identify, for example, on our real-time alerts, we'll see somebody who's high risk that comes in that we've never had. So it comes across the portal. I got a real-time alert. And you start, the first thing you see is I haven't done an HRA. Well, if I haven't done an HRA, it means we've been trying because we've already made 10 phone calls, okay? And then I look and sort of say, you know what, I can see on the portal, I can see this patient's a frequent media utilizer. What we do is we use our non-clinical person to go and engage the patient in the emergency room. First of all, they're less expensive. I think more importantly, they can start to connect with the patient because they're from the community. And they go and see the patient in the emergency room and start to connect. So we use non-clinical people for that. A lot of the clinics, including Mondale, have nutritionists, and they'll run classes, for diabetic class, whatever. So we'll have diabetic educators and we'll have nutritionists. And we trained a lot of our health educators were again community people that we trained in asthma and diabetes and whatever. So again, it doesn't have to be. I think when we focus too much on making sure, well, this person has to be a nurse or has to be an LPN, has to have this. I think it's first of all not practical because the workforce is not there for us to do that, and I think it's really expensive. And we need to use the resources there, and we need to empower our patients. And a lot of our patients really react and respond much differently to a community person than they do from an outsider who is clinically trained.
Is there a specific questionnaire that you use for the health risk assessment?
Yeah. So we went to the literature, and guess what? We didn't find anything. So if you're looking for something in the literature that's validated, and that's where we started to work and develop our own. So the one we came up with was, and the first group that went to mandatory managed care in Illinois was the ACA adult population. So there's no historical claims data. So if somebody's uninsured, I'm not going to be able to get the historical claims data. So our HRA we developed, we did ask about, major diagnosis. We focused on those that are the PQI type diagnosis, so those that are really ambulatory sensitive. So your CHF, your asthma, your COPD, your diabetic complications. So we asked about 4 or 5, SMI. So we asked about that, and we asked about had they been hospitalized in the past 12 months, and how many times they've been in the emergency room in the last six months. And then we asked those 10 barriers to care, and we couldn't find them in the literature. So we just sat down with clinicians and sort of said, okay, what is it in your experience that when patients don't do what you really would like them to do, what are the reasons that we could fix? And so that's really where we focus on those 10 risk factors. So that's how we came up with our HRA. With my hat on with Health Management Associates, we contract with a lot of health plans, and so I've seen their HRAs kind of thing. But a lot of it's just, most of the stratification you're seeing out there is really based upon diagnosis and utilization pattern. It really isn't getting at the social risk factors. And our hypothesis that I think is coming true is it really is those type of barriers is really what we can most impact and really should be focusing our efforts on.
Can you hear me?
Yeah.
The second question is that I think that you had mentioned using non-clinical personnel for handling some of the mental health issues.
Yes.
Can you comment on that?
Yeah. So if you look at this, are you familiar with the collaborative care model? So the collaborative care model came mostly out of Washington State. And the initial collaborative care model is using clinically trained people. But the idea is that you screen for depression. Everyone gets a PHQ-2. If it's positive, you get a PHQ-9. And if you're depressed, then on the collaborative care model, the first step is obviously the PCPs are doing what they should be doing, but also they then have a care manager who's following up on those patients. So they're meeting the patients right at the time. There's a warm handoff, and then they're doing follow-up phone calls and sometimes face-to-face with them and monitoring their depression. So with each one of the follow-ups, you're repeating the PHQ-9 if it's depression that you're following. So that's the traditional collaborative care model. We just didn't feel like we could do that. So there's a form of that called Diamond, and Diamond was a collaborative care model that used non-clinically trained patients. It was tested up in 3 states Minnesota, I know, was one. I can't remember the other two. In FQHCs using non-clinical. And actually, as I was telling Deb, in 2011, CMMI gave about 100 groups around the country Innovation Challenge grant money, and one of them was to test the diamond model. So you're going to see data that's going to come out this I think early this next year. I know the person who wrote that grant, and I've had conversations with her, and they're getting really encouraging data. So I think there is one study that's out there that I could send you that looked at the impact of using non-clinical people. But really what that non-clinical person does is they're really becoming a friend and the follow-up and sort of care. And then what you do is you hook up that non-clinical person with a clinical behavioral person who goes over your cases usually for 1 to 2 hours once a week. So what you're doing is you're bringing to that behavioral person. These are my patients because I'm doing a PHQ-9. And this person's PHQ-9 is 18 and it's not getting better, okay? Then that's a patient that I need to be talking with the clinical. And then you become the in-between. So sometimes that clinician saying, I really think what PCP needs to do is this. Or sometimes they're saying, what, I really think I need to see this patient face-to-face. And so sometimes that is. And so you're using this non-clinical person to sort of be the bridge. They're becoming the contact, trusted member of the team that builds the face-to-face relationship. And they're really tying together the behavioral specialist. And it's a way of really being able to triage who is it. Because right now we do a terrible job, particularly the Medicaid population, of getting the people who most need to be seen by the behavioral specialist clinicians. And it's really a first come, first serve, whoever gets their foot in the door. That's the way that happens. So by far, most of the behavioral issues for our Medicaid population are not getting addressed because there's not capacity. This is a way to really expand the capacity and also prioritize and get the right people to see the clinicians. Yes.
So what's the training model that you use for the community health workers that you're utilizing?
So what we did was we had an initial 2-day training, and we continue to do quarterly training. But the more important thing we do is we have a peer support group. So what's happening is that on a monthly basis, the leads for care manager from each one of the organizations are coming and bringing their cases, and then they're expected to go back and do that same type of peer report back in the FQHC. So that really is the model. So we'll bring them together and we'll do a 2-day training on motivational interviewing, for example. And that happens on a regular basis. I won't come and teach them about diabetes or asthma or whatever. But I think the real valuable thing, most valuable thing to me, is that we're doing those case reviews, and the peers are really learning from each other as they kind of go through their cases.
Jones, I had a question about your comment at the beginning about your training here and how you felt unprepared to do, not unprepared, but less prepared than the inpatient setting when you went to outpatient. So I am very thankful that we have Lucent, and that will be for 2 residents per class. So I'm from the pediatric side, and about 50% of each class goes out into general pediatrics. Is there anything that you could recommend during residency that these residents could do to better prepare for outpatient?
Yeah, I mean, things have changed, obviously, when I was here 30 years ago. I mean, our outpatient experience was mostly patients that we took care of on the inpatient side, and then we followed them up in the clinic. So they were really your patients that had 5 medical problems, and they were in the hospital a lot, and that was our outpatient experience. It sounds like it's improved since then. It sounds like you have much more of a broader general population, so I think that's good. I also think that what we tried to do at Lawndale was we would give people a month rotation. And so we would have people that would come in. In fact, Deb said she trained at Lawndale when she was a resident. So that's one opportunity, is to get out and sort of get that difference out in the community. And then I think with just like they've done with pediatrics here with friend family, is have some of the continuity clinics at least an option to be out in the community. It really is. It's a different experience being out in the community. I suspect. Again, I don't know the community, but it really is probably a different experience, and it allows you to sort of say, is that what I want to do? I think you guys are you have lots of options when you finish from UFC, and you may go into primary care research, you may continue to work in this kind of setting, but you also want to sort of say, maybe I should go have an impact out in the community and do my research there. I think by taking advantage and having that type of experience, if you have the option, I would certainly do that.
know the fact that in the pediatric department, we're doing exactly that. Our house staff do all their continuity of care clinics out in the community, and now 3 different FQHCs in the area. And I think they're getting the kind of experience that you're describing. I was wondering, since we're talking about pediatrics, a lot of your information and your presentation was focused on adult-related care. So have you looked at this model as it relates to kids?
Yeah, so so of our population, a third of our 80,000 are the ACA adults. And then if you look at our TANF population, which is the other 2/3, only about 20% of them are adults. But most of the rest of it. So we have a separate pediatric HRA. So we had the pediatricians sit around the family practice officers. Okay, what is it that, and our HRA for pediatrics is significantly shorter than it is for, so, but also looked at those same social risk factors, because again, it's the families that often do that. As far as when we look at our data, the number one diagnosis, actually behavioral health related inpatient for pediatrics is really high on the list, but asthma is pretty much over. Well, obviously, once you get past the neonatal stuff, okay, the whole thing as far as neonatal is a huge cost to the Medicaid population. But if you get beyond that and the older kids, asthma is right near the top, but then behavioral health is at the top. So we have to really learn what is it we're going to do to start to manage those. And this year we're focusing on behavioral health, and we're going to have to figure out what does that mean for pediatrics. Part of the problem with our HRAs is that even for adolescents, is the parents are answering the health risk assessment. So it really, and a lot of them we've tried sometimes to be able to talk to the adolescent alone, and there's some hesitation by that. So if you're trying to ask about the screen for depression with your HRA, which we do with adults, and you got the parent answering it, if there's abuse issues, or like you'd love to be able to say, do you feel safe? Do you feel safe at home? Okay, which is one of our questions on our HRA. Do you feel safe at home? Well, guess what? The parents answering that question, you're not going to get the answer that you want. So that's where it really comes down to more at the practice level when they're doing it. Because it's particularly those parents have a reason that where there's potentially an issue, you can believe they're not going to put the adolescent on the phone.
I want to do 2 or 3 things. I want to invite people to stay for a few minutes. We have some refreshments in the lobby, and talk to each other, talk to Dr. Jones. I also want to introduce Julie Dressmacher is our recent project manager. We came over a month ago, and yeah, Donna, please. So I want to thank Dr. Jones very much for coming.
My pleasure. Thank you.